Hi, I'm William McEachern. I'm an assistant professor of pediatrics at Emory University School of Medicine and one of the pediatric cardiologists at Children's Healthcare of Atlanta Cardiology. Today I'm going to be talking to you about critical and cyanotic congenital heart disease. I hope that you find this talk helpful for you. And if there's any questions that arise after I finish, please do reach out to our team. They'd be happy to put you in touch with me, and I'm happy to answer any questions that you may have. I wanted you to be able to put a face with a name, so I have my camera turned on, but I'm going to turn it off now just so we can kind of focus on the slides and the contents of them. I have no relevant disclosures. So there was an interesting paper in the journal Pediatrics back in August 2015 that looked at variation in prenatal diagnosis of congenital heart disease in infants. And for that and as you'll see on this next slide, there was moderate amount of variation across the United States, kind of regionally. But overall, the U.S. detection rate back in 2012 was 42%. So that means that we're missing more than of uh, half of the forms of congenital heart disease that were eventually recognized postnatally. The good news is the majority of those were more minor forms of congenital heart disease that might not necessarily have, affected the delivery plan. Things like atrial septal defects, ventricular septal defects, maybe partial anomalous pulmonary venous return. But some of them were more significant and things that we ideally would have liked to know about prenatally. Things like coarctation of the aorta or tetralogy of flow, or even hypoplastic left heart syndrome. Um, and so kind of looking at this map, you can see that, again, as noted, the overall U.S. detection rate was about 42% in 2012. You can see the variability by region that ranges anywhere from 24% um, in Texas and the surrounding states, and then up to 46% kind of in the Mid-Atlantic region. Um, you can see here in the Southeast that the detection rate was right around 40%. In terms of congenital heart disease, there's three main presentations or physiologies that we like to think about. The first is that of shock, which is secondary to inadequate systemic blood flow. These individuals are gray, mottled, have on a ABG or VBG, they would have significant metabolic acidosis, and they may or may not have cyanosis. The second is those types of congenital heart disease that inevitably are associated with cyanosis secondary to decreased pulmonary blood flow. Those individuals, are, by definition cyanotic. They're blue, possibly with absolutely no signs of respiratory distress. They can be kind of comfortably cyanotic. And the third type of congenital heart disease, in terms of big categories that we think about, are that of those lesions that lead to overcirculation or too much pulmonary blood flow. These individuals tend to have normal saturations. They might be mildly decreased, secondary to the pulmonary edema, but generally normal saturations in those individuals are tachypnic and tachycardic, secondary to pulmonary overcirculation and congestive heart failure. And we'll take each of these three main presentations or physiologies in turn and look at some examples of each. So the first, decreased systemic blood flow or shock. The most generally left-sided obstructive disease is what's going to lead to a shock-like picture. Things like coarctation of the aorta, critical aortic stenosis, Schoen's complex, which just broadly is mitral stenosis, aortic stenosis, and coarctation of the aorta. More specifically, it tends to have a supravalvular mitral ring, a parachute mitral valve, and subvalvular aortic stenosis, for example, like a subaortic membrane, as well as coarctation of the aorta. But the Schoen's complex is very much a kind of a spectrum, and you often hear us refer to as an individual having a Schoen's light complex. And then the classic kind of hypoplastic left heart that we're gonna uh, delve into on several slides coming up. Um, Secondary to that, the various potential sites of obstruction to systemic blood flow, these individuals can develop severe ventricular dysfunction. The coarctation of the aorta, just kind of briefly, coarctation of the aorta can be what we call log segment or discrete. You see in this diagram here a more kind of just discrete uh, uh, coarctation that's just distal to the head and neck branches and kind of the region of what we call the aortic isthmus. That's kind of the classic discrete coarctation that fortunately in this case could be just repaired via the side via a left thoracotomy, would not require a sternotomy and completely opening up the chest. Although sometimes with more long segment coarctations, a midline sternotomy is necessary. Um, One of the most helpful things, to think about this diagnosis, obviously you kind of on exam would anticipate having, good pulses in the upper extremities or in the neck, and then decreased pulses in the, whether in the lower extremities, whether it's your femoral pulses, pedal pulses. Um, if you were to take blood pressures, oftentimes we'll ask, NICUs or newborn nurseries to obtain four extremity blood pressures. If there's a concern for developing coarctation. And so you would anticipate seeing a normal or even high blood pressure before the point of coarctation and then a low blood pressure beyond the point of coarctation. We typically look for uh, a systolic gradient of at least 10 and oftentimes, more than 20 millimeters of mercury between the upper and lower extremities to think about coarctation of the aorta. Hypoplastic left heart syndrome is a much more significant and severe form of a left-sided obstructive disease. Coarctation of the aorta just requires generally a single surgery to correct, although there is a decent risk of recoarctation over time. But hypoplastic left heart syndrome is much more significant in terms of these individuals are going to undergo uh, single ventricle stage palliation that we'll walk through in the subsequent slides. But as you can see here, on the left picture, you have a normal heart with, four normal sized chambers, including a normal sized right ventricle and left ventricle, uh, normal sized mitral and aortic valves on the left side of the heart. However, on the right picture, the patient with hypoplastic left heart syndrome, you can see that there's a notably hypoplastic or small left ventricle that results due to decreased flow prenatally in the setting of severe mitral stenosis or even mitral atresia. And similarly, secondary to decreased flow, you're going to get notable aortic valve stenosis and notable hypoplasia of that ascending aorta that you see there. Um, as you can see drawn, there is a PDA that from that main pulmonary artery to the aortic arch. Um, these hypoplastic left heart syndrome is a ductal dependent lesion, and so we would anticipate starting prostans as soon as possible after these individuals are born to ensure patency of the PDA until they can undergo their initial surgery, because it's only through adequate PDA flow that these individuals can get adequate systemic blood flow secondary to obstruction from the left side of the heart. All right, so typical clinical course of hypoplastic left heart syndrome. Fortunately, more often than not these days, it is diagnosed in utero prenatally, and so we can prepare the parents for what they'll face postnatally. We can ensure that these individuals are born at a level 3 NICU. We can ensure that that we're able to start prostaglandins um, and care for these children very carefully, very closely after birth. If it's not recognized prenatally, inevitably it will be soon after birth, as these kids can become very sick very quickly. The first surgery is usually in the first several days, or at least first couple of weeks of life, which is the Norwood procedure. We'll look at that, I think, on the next slide. These individuals post Norwood are very fat fragile. There's the numbers are improving, but historically, um, the mortality rate between the Norwood procedure and the second surgery, the Glenn procedure, approached 20%. I think that number's much closer to 5 to 10% now. Um, but these individuals may remain in the hospital for weeks, sometimes even until their second stage surgery at 3 to 5 months of life, and often require, NG tube feedings, NG feedings, G tubes, things like that. Um, uh, to ensure a kind of adequate nutritional intake. Their typical oxygen saturations are 75 to 85%. The second surgery, as mentioned, at 3 to 5 months of life is the Glenn procedure. These individuals are much more stable. After their Glenn, their typical oxygen saturations are 80 to 90%. And then the third surgery is at 3 to 5 years of life, the Fontan procedure. Um, this is post Fontan. They are least fat fragile and oftentimes will have near normal oxygen saturations of greater than 92%. Um, as we'll discuss, sometimes a fenestration will be placed in what's called the Fontan tunnel that leads to slightly lower saturations. But again, usually, saturations at least in the low 90s, if not the mid to high 90s. So to kind of walk you through each of these stages, the first stage, again, is the Norwood procedure, which involves uh, first aortic arch reconstruction. So you can see here that the that previously, notably hypoplastic ascending aorta here has been augmented. There's part of that uh, aortic arch augmentation, and the Norwood is what's called a DKS, which is the anastomosis of this um, native, hypoplastic native ascending aorta um, with the main pulmonary artery. And so you now have a situation where the right ventricle will be, uh, in a single ventricle palliation, will be the systemic right ventricle pumping out this now previous pulmonary valve, what we call the neo-aortic valve, out this ascending aorta. And this DKS is formed to ensure that as there's as uh, as the blood is pumped out of the heart forward across this aortic valve, that you get retrograde flow in this native ascending aorta down into the coronary arteries, because obviously coronary ischemia would be a very bad thing. And so it ensures that the coronary arteries are perfused that the heart muscle, excuse me, um, receives adequate blood flow. Um, so that's the first step, aortic arch reconstruction. The second, you can't see very well here. You have to kind of imagine it behind that um, ascending aorta, but is an atrial septectomy. So we just completely open up the atrial septum. That's to ensure that the pulmonary venous blood flow back to the left atrium, that well-oxygenated blood, is able to flow left to right, across the atrial septum, through the right atrium, across the tricuspid valve, and into the right ventricle, and then out to the body. And then the third step, as you can see pictured here, I've kind of ignored it so far, but is this conduit that's been placed between the right ventricle out to the pulmonary arteries to ensure adequate pulmonary blood flow. There's two different variations. This shown here, the RV to PA conduit, is called a Sano shunt. You can also instead, the surgeon can perform what's called a BTT shunt, which is a shunt from the innominate artery, the initial branch off the aortic arch, to the pulmonary arteries. So essentially, again, you do an aortic arch reconstruction with a DKS, atrial septectomy, and then placement of a conduit to the pulmonary arteries, whether it's a Sano shunt or a BTT shunt. And this is the first stage in single ventricle palliation and hypoplastic left heart syndrome. The second stage, again at 3 to 5 months of life, typically is the bidirectional Glenn. The main steps of this is that the Sano shunt or the BTT shunt is taken down, And as you can see here on this right picture, the superior vena cava, which previously had drained to the right atrium, has been kind of transected, and it is now anastomosed to the branch pulmonary arteries, and that is your new source of pulmonary blood flow for the next couple years of life, is um, is SVC flow to the branch pulmonary arteries. And then finally, you have what's called the Fontan palliation, which is kind of like the culmination or third stage of single ventricle palliation. And as you can see here, an extra cardiac conduit has been placed from the IVC, so an anastomos with the IVC here, and runs now up into the branch PAs. And so all of this systemic blood flow, both from the upper body and the lower body, is now draining appropriately, although not in the typical fashion, um, is draining to the branch pulmonary arteries, where that low oxygen blood can go out to lungs, pick up oxygen, come back to the pulmonary veins to the left side of the heart, and cross over that wide open atrial septum to down into the right ventricle and get pumped out to the body. And so that is now your your single ventricle circulation, which again ensures uh, relatively normal saturations. It ensures that the systemic venous, the pulmonary blood flow and the systemic blood flow are in series, as is typical in a normal heart. However, you have a situation obviously that's not anywhere near normal, and that the right ventricle is the systemic ventricle pumping out to the body. Sometimes, as I mentioned before, a small fenestration will be placed in this Fontan conduit. The reason being, the systemic venous return from the upper body and lower body are now kind of completely reliant upon kind of passive blood flow back into the lungs, and with higher pressures in the lungs at times, that you can get pretty significant uh, venous congestion. And so in those situations, particularly when individuals are um, kind of notably active and their pulmonary vascular resistance is higher, that little fenestration serves as a pop off, where some of this systemic venous return from the lower body can pop off into the right atrium. Um, the consequence of that oftentimes is lower saturations and potentially cyanosis, but cardiac output, lower saturations and adequate cardiac output is better than normal saturations and not enough cardiac output. So outcomes after Fontan, um, various things can result. One is ventricular dysfunction, particularly when, we're discussing this case where it's in the setting of hypoplastic left heart syndrome and it's a systemic right ventricle. There are certainly cases, other forms of congenital heart disease where we go down the single ventricle route, but the left ventricle remains the systemic pumping chamber. But particularly in the setting of a systemic right ventricle, ventricular dysfunction often results. Those right ventricles just morphologically are not made to be the systemic pumping chamber. Oftentimes, AV valve dysfunction can result. Hepatic congestion, liver fibrosis, and hepatocellular carcinoma are very real possibilities and risk in these patients long term. Again, secondary to that passive blood flow back to the lungs via the Fontan circuit. Protein losing enteropathy and plastic bronchitis are two complications that result from um, lymphatic abnormalities, which are kind of just inherent in this condition. Poor exercise tolerance is another potential risk. Inevitably, all of these patients have some degree of exercise intolerance relative to their peers. The setting of venous stasis, you can get thrombosis of the Fontan circuit or in the branch PAs that can cause real morbidity and mortality. And then oftentimes these patients do need cardiac transplantation. The risk, fortunately, these individuals are living longer and longer. into their 30s, 40s, 50s. But there is about a kind of a 30% risk or so, 20 to 30% risk that within 20 years post Fontan, there is some major complication, similar, like one of these listed above. Diving back into the NICU arena, we've kind of been. I wanted to give kind of an overview of single ventricle palliation, which I know is certainly interesting, but maybe a little less relevant for NICU providers. Um, but oh, I'm sorry, I need to go back one slide. Um, but just to speak briefly about prostaglandins, so we talked about um, the fact that hypoplastic left heart syndrome, as well as coarctation of the aorta, are until palliated, until repaired, they are ductal dependent lesions, and therefore we use prostaglandins to keep the PDA open. And I'll try to point out on for the rest of the talk where lesions are prostin dependent. Um, but it was initially approved for neonates in 1981. It maintains patency of the PDA, as I just implied. Common side effects to think about are apnea. So sometimes we have to provide a little extra flow to neonates on prostaglandins to prevent apnea. Sometimes it even requires intubation. Um, Fever can occur in similarly around 14% of individuals. And so that always, we run the risk of, is this fever just secondary to prostaglandins, or do we need to be concerned for sepsis? Does this need to change the potential surgical plan coming up because they're potentially septic or bacteremic? And so those are things that, NICU providers are often thinking about and managing. Other things that can result are flushing, bradycardia, hypotension, and seizures. All right, so those were, we just discussed the left-sided obstructive lesions that lead to inadequate systemic blood flow. We talked about specifically coarctation of the aorta and hypoplastic left heart syndrome. Now we're going to discuss cyanotic congenital heart defects, which include, I always learned it as five, but some people will throw in a sixth. But tetralogy of flow, transposition of the great arteries, tricuspid atresia, truncus arteriosus, total anomalous pulmonary venous return. And then the sixth that some people throw in is the hypoplastic left heart syndrome, which again is an issue with inadequate systemic blood flow, but often, typically, will present with cyanosis as well. But we're going to hit on those first five in the upcoming slides. So first, what is cyanosis? It's visible once the amount of deoxygenated hemoglobin reaches 5 grams per deciliter. In an anemic patient, the O2 saturation must be very low to become visible, oftentimes 50 to 70%. But typically, in a patient who is not anemic, it's visible when sats are 80 to 85%. You can see here in these pictures the difference between central cyanosis that involves uh, the face diffusely in the mucous membranes on the left there versus peripheral cyanosis, or i.e. acrocyanosis, that um, is usually just isolated to the hands, the feet, and sometimes the lips. And you can see that pictured there again in the middle picture and the one on the right. If you were to take the oxygen saturation of the individual on the left, it would be presumably low, let's say 80%, and the individuals pictured in the middle and right picture, it would probably be 95 to 100% completely normal. All right, so case one is a 36-week, former 36-week, uh, premature infant admitted to the NICU, has persistent hypoxia, no significant respiratory distress, and has a murmur on exam. And this is their chest x-ray. And the question is, what is the diagnosis? And that diagnosis is tetralogy of flow with the right aortic arch. I'll go back briefly here, but the classic teaching in tetralogy of flow is that of a boot-shaped heart, which you can see here. And then if you notice on our right, the patient's left, you don't have the typical aortic arch, knob of the aortic arch. which makes you suspicious that this could be a right aortic arch, and we'll talk more about the association of right aortic arch with tetralogy of Fallot. The other thing that's often associated with tetralogy of Fallot is the George syndrome. Um, uh, and so to review the anatomy of tetralogy of Fallot, um, in tetralogy of Fallot, you have a right side of the heart and a left side of the heart. However, there is the first part of it is there is pulmonary stenosis. That pulmonary stenosis is oftentimes multi-level, meaning as you can see drawn here, there is subvalvular stenosis, typically resulting from anterior deviation of the conal septum, this thick muscle you see right here. You can see that there's valvular stenosis, narrowing and thickening of the pulmonary valve itself, and oftentimes you may have supravalvular stenosis as well, so narrowing of the main pulmonary artery. Um, there is a large membranous outlet ventricular septal defect. You can see that defect here in the ventricular septum immediately underneath the aortic valve. That's the third part of tetralogy of Fallot, is an overriding aorta. And then the fourth part is right ventricular hypertrophy, or thickening of the right ventricle, which is secondary to the outflow tract obstruction across the pulmonary outflow. The severity of tetralogy of Fallot is dependent upon the degree of pulmonary outflow tract obstruction. If it's relatively mild, these individuals oftentimes may have actually near normal saturations. If it's more severe, they can have very limited pulmonary blood flow at all, and will be ductal dependent. And so we'll often, again, ideally we diagnose these things prenatally, but we'll try to determine prenatally if we think the degree of outflow tract obstruction will be ductal dependent or not, and whether prostaglandin should be started after birth. You guys, inevitably, you guys have heard about TET spells. So TET spells, all these individuals tend to have some degree of fixed obstruction across the pulmonary valve, across the pulmonary outflow, but then they can develop what's called dynamic obstruction. And so when they get, oftentimes when they get very upset, it can lead to increased dynamic obstruction below the pulmonary valve that leads to increased right to left shunting from the right side of the heart across the VSD and out the aorta, which leads to notable cyanosis. Just to hit on a couple more things related to tetralogy. As you can see here, this individual pictured here has DeGeorge syndrome. Very characteristic facial features for DeGeorge. Looking at this, let me just run through this really quickly. So this is just showing you again kind of how the typical blood flow and tetralogy of Fallot. I apologize, I didn't realize that this was going to work well. But again, you can see you get mixing of blood flow at the level of the VSD out the aorta, which can lead to purple blood, kind of decreased oxygen saturations, cyanosis in this setting. All right, so here's one I wanted to get to. So tetralogy of Fallot is the most common cyanotic congenital heart defect. It affects 4.7 out of 10,000 births. It represents 3 to 7% of all forms of congenital heart disease. Associated findings on that chest x-ray, we were suspicious that the patient had a right aortic arch. About 25% of patients with tetralogy have a right aortic arch, and about 11% have a left SVC. 10 to 15% have 22q11 deletion or DeGeorge, as we just talked about on that previous slide. Typically, we like to repair tetralogy of Fallot at 3 to 6 months of life. Sometimes we're pushed to repair it earlier if, for example, if we lose the PDA. Ideally we try to have a good sense of whether the PDA is going to be necessary or not to ensure adequate pulmonary blood flow. Typically, if we think we're going to need it, we'll start prostaglandins in the neonatal period, and then often perform a temporizing measure like a ductal stent or a BTT shunt to ensure adequate pulmonary blood flow until we can perform definitive tetralogy repair. Um, but at other times, we think a kid's gonna be okay. They go home, we follow them back in the outpatient setting, and they develop more significant outflow tract obstruction, and we realize, and including, including kind of developing TET, repeated TET spells. And so at that point, we realized, well, we need to perform this surgical repair sooner rather than later. And so we can certainly, our surgeons are very good at performing this at much younger ages, but ideally we like to get them to 3 to 6 months of life, where we perform two different but kind of relatively similar repairs. The classic repair is a transannular repatch. The other possibility is a valve sparing repair. But in the repair in general, the idea is that we open up the narrowed outflow tract, and so oftentimes again that they will perform a transannular patch, resecting a subvalvar narrowing or obstruction. They will completely open up the pulmonary valve, and then oftentimes we'll have to patch into the main pulmonary artery as well. As the text here says, and well, let me go back a step. We open up the outflow tract and then close the VSD. The idea being that these individuals now will have a somewhat normal biventricular circulation. The downsides to think about with a transannular patch repair, you've now completely disrupted the pulmonary valve. And so even though you've relieved the obstruction to antegrade blood flow, you've now essentially created, it's an essentially incompetent valve. And so you're going to have, severe or free pulmonary insufficiency that over time is going to lead to significant right heart dilation, which we'll talk about in a second. Secondary to that, as noted here, it will require late pulmonary valve replacement, usually around age 15 to 25, to prevent ongoing dilation and potential dysfunction of the right ventricle and the increased risk of arrhythmia in the setting of a dilated right ventricle. So more and more we're moving towards valve-sparing repairs. Sometimes the pulmonary valve is so small that it just precludes the possibility of doing a valve-sparing repair. But if we're able to resect the subvalvular obstruction and the supravalvular obstruction and spare the pulmonary valve, oftentimes a little bit of residual narrowing or stenosis is well tolerated if we can, and is preferred if we can reduce the degree of insufficiency. So I'm not certain if these are playing for me. I know that when we've recorded this previously, we had some issues with it showing up for you guys. So I hope this is showing up for you. I'll try to play that again if again, hopefully it's showing for you. But basically, you should see across this pulmonary valve, there's blue flow initially in systole, which indicates the antegrade blood flow across the pulmonary valve. And then you can see a whole bunch of red flow in the opposite direction in diastole, which is just free pulmonary insufficiency following transannular patch repair. If I play the other video here, again, it just gives you a sense of there's in the bottom frame here, you have the left ventricle in cross section, and then the right ventricle is not as well seen, but if you can see the picture above it, you can see that the right ventricle is traced here. That represents a big dilated right ventricle secondary to long-term free pulmonary insufficiency. And so, as mentioned before, pulmonary valve replacement is ultimately needed in a lot of these individuals. Classically, this has been a surgical pulmonary valve replacement. Following replacement, individuals spend 2 to 4 days in the hospital. It has an overall excellent prognosis and outcome. This valve will wear out with time, roughly around 10 to 20 years. Ideally, you hope you get closer to 20 years than 10. Relative to the next type of valve I'll talk about, there's a lower risk for bacterial endocarditis. And the good news is once you place this surgical valve, oftentimes you can place a transcatheter valve and obviate the need for future surgeries. down the road. Again, I'll try to play this video. Hopefully it plays for you. But again, if you're able to compare it to the prior video, you can see that you have that antegrade blood flow across the newly placed pulmonary valve that shows up in blue, and you have much less. You really don't see much in the way at all of pulmonary insufficiency now after the newly placed valve. And so the hope long term is that with decreased pulmonary insufficiency, that the right ventricle can remodel, become closer to normal in size, and ensure kind of normal function of the right ventricle and decrease the risk of ventricular arrhythmias. The other option is a pulmonary valve replacement. Again, I'm going to play this. I hope it plays for you. You'll slowly see over time that that this is uh, a a wire has been placed uh, across the pulmonary outflow tract, and they have positioned a valve in the main pulmonary artery, and they're slowly inflating a balloon that will then expand that valve and remain in place even as the balloon is deflated. The valve is the valve is appropriately positioned and kind of in place and will remain there and serve as a new pulmonary valve for this patient. But the benefits of transcatheter valve as opposed to surgical valve is shorter stays in the hospital. So just kind of you come in one day, go to the cath lab, get your new pulmonary valve placed, spend the night in the hospital, and you go home the next day with just a Band-Aid on your leg. No, there's no sternotomy. They don't have to open up the chest. There's no chest tubes needed. There is an increased risk of bacterial endocarditis relative to the surgical valves, about 5 to 8% over 5 to 8% risk over 10 years. This valve similarly will wear out with time. Again, about ideally you get a lifespan closer to 20 years, but oftentimes you might only get 10 years or less with these valves. And you can have a repeat catheter valve placement after an initial transcatheter valve. Repair tetralogy still requires lifelong follow-up, similar to most of these lesions, if not all of them. You know, there's always a possibility, depending on when an individual gets their uh, pulmonary valve replacement at whatever age that may be, there's a very good likelihood that they'll require subsequent pulmonary valves or other surgical or transcatheter procedures, including work on the branched pulmonary arteries that are oftentimes abnormal or small. Uh, Arrhythmia risk is very real. I've mentioned that, but 34% develop atrial tachycardia or SVT, 8.5% develop high-grade ventricular tachycardia, and there's a very real risk of sudden cardiac death. As you can see on this EKG here, there's pretty notable right bundle branch block. These individuals tend to uh, tend to have right bundle branch block post-operatively in the setting of the VSD patch, but then as they get progressive right heart dilation, the QRS duration can further widen, and classically a QRS duration greater than 180 milliseconds has been associated with increased risk of ventricular arrhythmia and sudden cardiac death, and so that can help us think about when we might need to go for pulmonary valve replacement. All right, shifting gears, our next form of cyanotic congenital heart disease is transposition of the great arteries. It is lethal. The natural course, untreated, is that it's lethal 90% by age 1. There's 30% mortality in the first week of life, 50% mortality in the first month of life. About 50% of these individuals need a balloon atrial septostomy in the neonatal period prior to definitive repair. And the operative mortality, fortunately, is relatively low these days, around 2%. But what are we actually talking about in terms of transposition of the great arteries? So as you can see here, um, the typically in a normal heart, the pulmonary blood flow and the systemic blood flow are in series. And in this case, they're in parallel, and and in the absence of any intercardiac mixing, they're essentially isolated from each other. So the low oxygen blue blood comes back from the body to the right heart and gets pumped back out the aorta to the body and then comes back. And so there's this complete circuit of systemic blood flow that never goes out to the lungs and never receives the oxygen that it needs. On the other side of the heart, on the left side of the heart, you have uh, pulmonary venous return, so well oxygenated blood flow that then gets pumped out the pulmonary valve, back out the branch pulmonary arteries to the lungs, and then back to the left side of the heart. So again, these two circuits, in the absence of intracardiac shunting, are working in parallel, and these individuals can become very sick very quickly, and from some combination of notable cyanosis and inadequate um, either pulmonary inadequate cardiac output. Um, so in order for this to work, you need two levels of intracardiac shunting. Now, oftentimes the atrial septum can serve as both. If we can have adequate bidirectional shunting across the atrial septum, you can get adequate mixing of adequate mixing of blood flow, such that even though these individuals will be cyanotic, they can be stable with saturations of, 75 to 90%. Generally, we consider this to be a ductal dependent lesion. There are certainly some centers that will, if they have adequate bidirectional shunting across the atrial septum, will allow the PDA to close. But oftentimes, having the PDA open will help ensure adequate pulmonary venous return, which encourages left to right shunting across the atrial septum, and ensures kind of adequate oxygenated blood getting out the aorta on the right side of the heart. In terms of predicting the need for an urgent balloon atrial septostomy after birth, it's very challenging. Generally, generally we rarely will see a restrictive atrial septum in utero. None in a recent series that was published. And one review of 26 fetuses with transposition and prenatal diagnosis at Stanford over 10 years. 14 of them required balloon atrial septostomy. Increased likelihood of BAS was seen in those with a hypermobile atrial septum, bidirectional PDA shunt, or restrictive PFO or PDA. In terms of, let me go back because I didn't realize we didn't have a slide on the surgical correction of transposition, but these individuals will ultimately undergo arterial switch, ideally in the first week of life, where uh, the proximal MPA and ascending aorta um, are essentially switched, and the coronary arteries are translocated at the same time as that arterial switch. And essentially, the um, the nice thing after that is that these individuals essentially have normal circulation. There are long-term risks in terms of the function of the neopulmonary valve and the neo-aortic valve. Uh, there is also, in addition, when the arterial switch is performed, something called a Lecomte maneuver is performed along with it, which is kind of anterior translocation of the pulmonary arteries in front of the aorta to ensure that there isn't compression on the coronary arteries. Um, that can lead to branch pulmonary stenosis, which sometimes requires intervention down the line as well. All right, tricuspid atresia. Um, so this is another form of cyanotic congenital heart disease where there's inadequate pulmonary blood flow in the absence of a PDA. And it is another one that will go down the single ventricle route. So in this case, you can see that the tricuspid valve has not formed, and so the low oxygen blood coming back from the body into the right atrium has to shunt right to left across the atrial septum, and so an adequate atrial septal defect is important in tricuspid atresia. And that low oxygen blood then shunts over to the left atrium, mixes with the high oxygen blood coming back from the lungs, and then gets pumped out to the body and will go across the PDA and provide pulmonary blood, ensure adequate pulmonary blood flow prior to surgical palliation. As pictured here, oftentimes there is a VSD that can also help ensure some degree of antegrade pulmonary blood flow. And depending on the size of that VSD and the size of the pulmonary valve, sometimes you can get relatively adequate pulmonary blood flow across there. But in general, we consider tricuspid atresia to be a ductal dependent lesion and start prostaglandins postnatally. Again, going back just one slide. Tricuspid atresia is a lesion where those individuals will go down the single ventricle pathway. It's a little bit different than hypoplastic left heart syndrome in the sense that oftentimes they do not require the stage 1 palliation with Norwood. Typically, we will just do a temporizing measure such as a ductal stent or a BTT shunt prior to the stage 1 the stage 2 palliation, the Glenn, and then they ultimately get the Fontan. Truncus arteriosus is a very interesting cardiac anatomy. So as you can see pictured here, you have typically a decent sized right side of the heart and a decent sized left side of the heart. However, there is a large VSD with a single truncal valve that overrides that VSD. And you can see that both the ascending aorta as well as the the pulmonary arteries originate from this single trunk. It's very, very interesting anatomy, but you can see here that the classic repair for truncus is to close the VSD, such that the truncal valve becomes the neo-aortic valve, and then to place an RVPA conduit to the branch pulmonary arteries, which essentially now becomes, your neo-pulmonary valve and main pulmonary artery. And so these individuals also, have a somewhat normal biventricular circulation. However, those conduits, given that those conduits, the RVPA conduit is placed at a relatively young age, these individuals outgrow those conduits and oftentimes require serial upsizing of the conduits. The conduits can also, even once they're of an adequate, adult size, still deteriorate over time and lead to the need for either conduit replacement or transcatheter pulmonary valve placement. Other things to note, particularly in the neonatal period, these individuals require surgery and ideally in the first week of life, mainly because you can get significant runoff into the branch pulmonary arteries that can lead to coronary ischemia in the setting of a single kind of truncal valve and truncal root. And so we try to repair them before they can get notably sick with coronary ischemia, prior to the pulmonary vascular resistance completely normalizing. Other things to note, the other thing that in the neonatal period will significantly affect kind of how these kids do clinically and how stable they are prior to surgery is the function of the truncal valve. A well-functioning truncal valve is always a nice thing to have, but if there's significant regurgitation or insufficiency of that valve, that it further exacerbates the risk of coronary ischemia, and so those kids can be or just inadequate systemic blood flow, and so those individuals can be pretty sick pretty quickly, and an abnormal or incompetent truncal valve can significantly affect the long-term prognosis in these kids as well. It can be a real bear to figure out how best to manage these patients when they have a poorly functioning truncal valve. All right. Well, we gave you the answer here. The answer must be obstructive TAPVR, but it's only the answer in one of these two cases. And so there's two different chest x-rays right here. The one on the left is a term neonate with cyanosis since birth, even on a FiO2 of 100%. PaO2 is 28%. You can see the chest X-ray there. They tell you that the BNP is 10,000. Conversely, here's a 4-month-old former 24-week gestation neonate who remains intubated at 4 months old, who has a relatively normal BNP of 200. And the question is, what are the two diagnoses? Well, we can tell you the one on the left is going to be obstructive TA-PVR. Even though these two chest X-rays look kind of similar, the whiteout in the patient on the left is secondary to obstruction of pulmonary venous return and therefore resulting pulmonary venous congestion. The one on the right is kind of more consistent with chronic lung disease from secondary to premature lung disease. So, and there's several different forms of TA-PVR, which all of them represent total anomalous pulmonary venous return. So the pulmonary veins going back somewhere other than to the left atrium. You can have supracardiac TA-PVR, you can have intracardiac TA-PVR, or you can have infradiaphragmatic TA-PVR. Pictured here, you see infradiaphragmatic TA-PVR with all four pulmonary veins draining to a confluence behind the heart, behind the left atrium, but then draining down via this kind of descending vertical vein over to an hepatic vein right near where it comes into the inferior vena cava. We show this picture because infradiaphragmatic TA-PVR is most likely to become obstructed, and that is when these kids are really sick. So some kids, if the pulmonary veins are not obstructed, will be somewhat cyanotic, but actually can do well clinically for several weeks or even a couple months before we perform the definitive surgical repair. But these individuals with obstructed pulmonary veins can get very sick very quickly with notable cyanosis, inadequate systemic blood flow. And so it's kind of a mixed picture of both. And oftentimes, these individuals have to be rushed to the operating room within the first few hours of life. Just some special flavors of cyanosis in the NICU. The first is differential cyanosis. This occurs when the oxygen saturations in the upper body is higher than the oxygen saturations in the lower body. This most commonly results from persistent pulmonary hypertension of the newborn, where you get normal oxygen saturations out the ascending aorta, but then secondary to notable pulmonary hypertension, you have right to left shunting across the PDA, which leads to some degree of mixing of blood and therefore lower oxygen saturations if you measured it in the foot, for example. The other less common situation where you're going to see this is if you have an interrupted aortic arch or severe coarctation of the aorta with persistent pulmonary hypertension, where again you get normal oxygen saturations in the head and neck vessels, but secondary to right to left shunting across the PDA, which in this case would be absolutely necessary in the setting of interrupted aortic arch or coarctation. You're going to get lower oxygen saturations in the lower extremities. This is an interesting case. This patient is a little older than any of us are probably comfortable with, but a 52-year-old woman with a murmur and differential clubbing. What does she have? Look at her pre and post ductal saturations. So you can see that oxygen saturation in her hand is 95%, oxygen saturation in her foot is 80%. You can also might note the clubbing you see in her feet. This is a case of an either unrecognized or untreated patent ductus arteriosus, a PDA that's been present for 52 years that would have been shunting continuously left to right for many of those years, but then ultimately with that left to right shunt, the lung vasculature gets beat up, you develop higher pulmonary vascular resistance, ultimately significant pulmonary hypertension, such that the PDA starts to shunt right to left, and you get this differential cyanosis. A different flavor is reverse differential cyanosis. And so this is actually where you have lower oxygen saturations in the ascending aorta and the head neck vessels relative to the uh, descending aorta and lower extremities. And this will, as you can see pictured here, can result with detransposition of the great arteries with severe pulmonary hypertension or with coarctation of the aorta. The other situation, again, that you'll run into very uncommonly, but certainly there, if you see persistent differential cyanosis, there's certainly a good reason to be in touch with your favorite cardiologist because there's very few things that cause this, and so it's worthwhile further investigating. But the other is supracardiac TAPVR, which kind of has to do with streaming across the right atrium. So as you can kind of see here, um, these anomalous pulmonary veins come up to this vertical vein. So you can see the red arrows here and come over to the SVC. And so you get mixing of um, blood flow in the SVC that then streams across the right atrium, across the tricuspid valve, and goes out the MPA and across the PDA versus and so that's kind of mixed blood. It's going to be a little bit higher oxygen saturations than the systemic venous return alone, whereas you get um, that low oxygen blood coming back from the lower body, the IVC that streams directly across the atrial septum to the left atrium and goes out the aorta. And so in this case, you actually just due to streaming effects, probably are going to have lower oxygen saturations um, going out the ascending aorta relative to um, across the PDA into the lower body. All right. As all of the newborn nursery providers, all the NICU providers are well aware of, on every baby who's born, we perform CCHD screening after 24 hours of life. Um, you know, the good thing is that we're able to pick up a large number of we're able to pick up a lot of the congenital heart disease that might otherwise have gone unnoticed. The downside of it is that it only about 20% are true false positives. Um, and so, it oftentimes is picking up other things like lung disease, sepsis, persistent pulmonary hypertension. Um, 50, as this purple box says here, 53% of failed CCHD screens with a normal echo result in a diagnosis of unsuspected pneumonia. And here's just a little chart of all those, the breakdown of the distribution of disorders, causing uh, causing failed CCHD screens. And so it looks like here, only a total of, only about 13% were secondary to true congenital heart defects, whereas a fair number were secondary to, as mentioned, pneumonia, just transient tachypnea, persistent pulmonary hypertension, pneumothorax, and other kind of less common things. It's good that we're not missing critical congenital heart disease, but also we pick up a lot of things and oftentimes have false positives. The third and final thing that we'll just talk about relatively briefly over the next couple slides is pulmonary overcirculation. The forms of congenital heart disease that lead to pulmonary overcirculation are a complete atrioventricular canal or AVSD, ventricular septal defect, a large PDA, and an AP window. And we'll just talk about, and then as mentioned earlier, these individuals oftentimes will have normal oxygen saturations. They tend to, but they'll be tachypnic, tachycardic, and oftentimes will have poor feeding and poor weight gain. Complete AVSD is probably, we'll use as kind of our classic example of a lesion that leads to pulmonary overcirculation. I will try to play this video here. Hopefully it plays for you guys. But you can see here that you have a good size right ventricle, a good size left ventricle. The right ventricle is the one here on the left side of your screen. The left ventricle is the one here on the right side of your screen. But you can see that there is a large primum atrial septal defect here above that AV valve. You can see that there's a single common AV valve instead of two separate, tricuspid mitral valves. And then there's a large inlet VSD immediately below that common AV valve. And so that is the kind of complete AVSD with a primum ASD, common AV valve, and large inlet VSD. Um, just to go back briefly, complete AVSDs tend to be repaired around 4 to 6 months of life. Ideally, these individuals can be managed medically prior to definitive surgical repair. We like to wait 4 to 6 months because um, the the valve the valve tissue is very kind of thin and friable when they're particularly young. And so if we can get them even to 4 to 6 months of age, it makes the repair a lot easier to perform. And the outcomes oftentimes in terms of the long-term valve function are much better as opposed to trying to do them very early in life. The sometimes, oftentimes these patients we have to treat with diuretics. We have to treat with fortified feeds or even tube feeds to ensure adequate nutrition and weight gain prior to surgery. If these individuals are getting into a lot of trouble earlier than we think that we can perform a definitive repair, sometimes we'll place a PA band to restrict pulmonary blood flow. We didn't hit on these things too much, but things like, again, ventricular septal defects, PDAs, things like that, that can cause pulmonary overcirculation. The timing of, either surgical or transcatheter intervention on those lesions kind of depends on just the clinical scenario, how significant the heart failure is, how significant the symptoms are, um, that type of thing. All right, so just in review, this is the last slide. If you remember nothing else from the talk today, cyanosis without respiratory distress is heart disease until proven otherwise. Differential cyanosis with respiratory distress is persistent pulmonary hypertension of the newborn almost all the time. Reverse differential cyanosis is oftentimes transposition of the great arteries with coarctation of the aorta. Cyanosis with white lung fields is TAPVR, and cyanosis with dark lung fields is tetralogy of Fallot. I didn't touch on that as much with a chest X-ray, but the idea being lesions that are leading to inadequate pulmonary blood flow, the lung fields will appear dark. Well, thanks so much for your attention today. Hope you guys enjoyed it. Please do reach out if I can answer any more questions for you guys. Thanks so much.